agonists and the beginning of the adrenergic agonists. Okay, so I don't know what we're gonna do. Maybe we're gonna slow down or something. But anyways, the good news about this section is that we still have 3 lectures to be done. Okay, so adrenergic antagonist, will be done with it. Then we have 3 more lectures about the central nervous system, and that's it. You'll be done. Okay. For the, again, repetition for the second midterm, although we're not obliged to do a second midterm, we can just stick to the first midterm and that's it. But if we want to do the second midterm, let's plan it again next week for the first 4 lectures of the autonomic nervous system. Okay, because I've been receiving emails, although we have mentioned this already. Okay, so for those who send me emails, make sure that you know that they're in the first 4 lectures. Probably that's going to be mid next week. Okay, so Monday, Tuesday, something like that. Haidar?
Hi, Doctor. Good morning.
Good morning.
Doctor, for the chapters adrenergic agonist, it's not included in midterm?
In the final.
Yes, it just include in final, but not included in midterm, second midterm.
100%.
Okay, thank you so much.
But my suggestion, guys, is to always read through the lectures, okay? Because it makes it easier when you want to come back to them and study them again, okay? Now, let's go back to the lecture and try to finish as much as possible, maybe. We'll see how much we can finish today. Okay, so we said in adrenergic agonists, we first started with the alpha receptor antagonists. Last time we talked about the non-selective ones. We said the alpha-2 selective are not used clinically, and we have the alpha-1 selective, which we're going to talk about today, okay? Then, take a look. The alpha-1 selectives are these: prazosin, alpha-usacin, doxazocin, psilocybin. Okay, so we have a number of drugs that all end with ocin, okay? Now, when I block alpha-1 receptor, guys, what's happening to the smooth muscles usually? Relaxation, excellent. So, smooth muscles would be relaxing. If those were the vessels, that will lead to vasodilation, okay? Which is a treatment for patients with hypertension. That makes sense? All right. Okay. What's going to happen when we have vasodilation? Reflex tachycardia, right? Which is normal. But remember here in the non-selective alpha, because alpha-2 antagonists, when it's non-selective for alpha-1 and alpha-2, when I block alpha-2 receptors, there's also very bad tachycardia. So here we have tachycardia, but the alpha-1 selective, the tachycardia is not as bad because I don't have an alpha-2 blocking effect. It's only about alpha-1 blockade and the effect of reflex tachycardia, not because of alpha-2 blockade, because that's not going to happen. Okay, so the tachycardia in this alpha-1 selective drugs is not as bad, but it's still present. So why do we use alpha-1 antagonists other than for treatment of hypertension? Okay, so there is a condition that happens in men, which is called benign prostatic hyperplasia. Okay, guys, are you familiar with the prostate gland? You're not? Do you know what the prostate gland is? Let me explain what the prostate gland. Guys, the prostate gland is a gland that's present in the male genital system. Okay, it's not present in females. So when we talk about prostate, we're talking about men. Okay, the prostate gland has a very important role in producing the semen, okay, of the man. And where is it located? It's located, so if this is, guys, the urinary bladder and this is the urethra, the prostate is around the urethra. It goes around it all the way. This is a cross section, so this is a like cut, okay? So if you want to see the whole picture, the prostate is surrounding all the way the urethra, okay? The thing about prostate, it's a normal for the prostate in older men to have it enlarged, okay? So the prostate can be bigger sometimes in older men. And that enlargement, or what we call as hyperplasia, can be benign, okay? Because also prostate glands can be a gland that is subject to having cancers. Okay, so prostate cancer is one of the cancers that can be present in men, but at the same time, also it can be, and which is more and more common, a benign growth. So that can be only an enlargement that is not cancerous. So this is why we call it benign prostatic hyperplasia. Is it clear? All right.
Yes, doctor.
So why does it happen? Simply, it can happen because of age. So older men can have it. What's the problem? We said that the prostate gland surrounds the urethra. So when it gets enlarged, look at the urethra. It becomes smaller and it compresses the urinary bladder. So the patient is going to start having problems in urination, like hesitancy, so difficulty starting urination, or frequency in urination, so urination more frequently than usual, urgency, a sudden feeling that the person has to urinate, okay, nocturia, which is the need to urinate more frequently at night. You know, usually a normal person would not want to go urinate at night for so many times, and not 5-6 times a night. This is not normal. But patients with prostatic hyperplasia, yes, they might experience that. Okay, are the symptoms clear, you guys, and the pathophysiology? Okay. Now, because the prostate gland, okay, and all of those, the system, the urinary system, all of those are muscles. In order to relax them, we need to block alpha-1 receptors. Okay, so this is the first use for alpha-1 selective receptor antagonist. And this is the major use. Some other uses can be related to hypertension. Okay, we just mentioned it. So it can be related to blood pressure. Okay, because it relaxes the smooth muscles of the vessel, so it causes vasodilation. And also it can cause, or it can relieve congestive heart failure, but this is not the best drug of choice, okay? Now, let us talk a little bit about heart failure, and I will tell you, just explain what heart failure is to you guys. Are you familiar with heart failure? Did you take it in pathophysiology? Okay,
yes, we took it.
Amazing. So let me just refresh your memory again on heart failure. So in your opinion, guys, when I say heart failure, does it mean the person is dead or alive? Yani, is it an emergency or not?
Emergency?
Well, this is what you might think. But in fact, this is not the case, because heart failure is not an emergency. What is an emergency is a heart attack, or a myocardial infarction, or a cardiac arrest. So these are different terms. Okay, so now let's focus on heart failure. Heart failure is when the heart is weak, is not pumping as strongly. Okay, This is it. This is heart failure. It's not an emergency, but it requires treatment. There's a difference. Yani, the person is not going to die right away. But what's going to happen is that they might have symptoms, they need proper care, and they need medications as soon as possible. Okay, so today in the lecture, we're going to have more than one drug that targets heart failure. Okay, so guys, let me ask you now a few things. Why do the ventricles and the atria and the ventricles, why do they contract? To push the blood out. So this is the reason why they contract. Okay, now you tell me, guys, what are the names of the vessels that bring the blood back to the heart?
Vena cava.
Vena cavas, right? So those are veins. That's right. So those are veins. But what about the vessels that can bring the what do you call it? The blood out. What do you think?
The aorta.
That's the aorta. Excellent. Bringing it back to the whole system. Okay, and those are arteries. Okay, so remember, guys, there's a rule. The more blood there is in the heart, the more force it needs to do in order to push the blood out. Okay, so this is the rule number one. The more the blood in, the more the blood coming back, the more the blood there will be in the heart, the more it needs to contract. So guys, when a patient's heart is failing, the heart cannot pump. The heart is weak. So what is one solution? I need to decrease the load on the heart. I need to make the heart more relaxed or less loaded. Okay, so rule number one, I want to decrease the amount of blood coming in, because when I decrease the amount of blood coming in, what am I doing? I'm kind of relaxing the heart so the heart doesn't have to pump more. Okay, and this is what we call as the preload. All right, guys, so this is what we call, let me write this down. So this is, guys, what we call as the preload. So the preload is the amount or the volume. Okay, let me just write it down. So the volume of blood reaching the heart. So guys,
it's done by constructing the vessels.
بالعكس.
We dilate them.
Yes, exactly. So through dilation. But guys, the preload, the amount of blood coming into the heart, is it related to the veins of the arteries? What brings the vessels
the veins,
back?
It's coming.
Exactly. So this is why
blood to the heart.
Exactly. So this is why it would be smart to dilate the veins, which is called usually venous dilation. Guys, the first idea makes sense to everyone? So we're doing venous dilation or dilation in the veins so that less amount of blood can reach the heart at once, and the heart would be a little bit more relaxed because it's weak and it cannot pump or do so much work. Okay, so we'll be decreasing the preload. This is what we call the preload. Is the first idea clear?
Yes.
Okay. And what about the afterload? Listen, this is something else. So we said the first factor that determines how the heart would contract is how blood is inside of it or reaching it. And we agreed on the first part. Now, what about the second part related to the arteries? The arteries all over the system, they're constricted. The arteries control the blood pressure, so they are constricted the whole time. The more they are constricted, the more the heart needs to pump to overcome this constriction. Okay? And this is what we call as the afterload. So this is the resistance in arteries. Okay, and it's related to the arteries. So in order to help the heart, not do an extra load, not contract too much, not to feel their weakness. What should we do? We should dilate the vessels, so vasodilation of arteries. Okay, so vasodilation of arteries, and the result would be the heart doesn't have to pump so much, doesn't have to work after load so much, because the arteries are not too constricted. There's no resistance in the arteries. Makes sense, guys? So let me summarize them. When the heart is weak, when we have heart failure, it would be smart to dilate both the arteries and the veins, but for different reasons. I want to dilate the veins because I'll be decreasing the amount of blood coming in, so the heart doesn't work so much. And in the arteries, I would rather dilate the arteries. Why? Because the arteries in this case will not be too constricted, and the heart doesn't have to pump a lot or work a lot to counteract this resistance. Okay, so bottom line, to treat heart failure, okay, it would be smart to dilate both the arteries and the veins, or any of them. That would help. Okay, so that will reduce the preload and the afterload, and that will cause the patients or help them with their symptoms. Okay, now most of those drugs, guys, are used for the prostate, not for لا heart failure ولا hypertension, but they can be used sometimes. But anyways, the alpha-1 antagonists, what are their adverse effects? Remember, guys, these drugs cause vasodilation. When they cause vasodilation, that means they might cause hypotension. Remember, guys, what's the meaning of postural hypotension? Let me describe it for you. Yes, Safa.
Like it's when someone stands up, they feel dizzy.
Exactly, this is it. So this is what we call as postural hypotension. Okay, so patients usually with the first dose only, they might have postural hypotension. Okay, and this is what we call a syncope. Syncope is when someone faints, but this is a scientific word of fainting. Okay, so the patient might feel syncope and postural hypotension with the first dose. So what do we do in order to help? Number one, I start always with 1 milligrams. I start a very low dose, okay, and then I slowly titrate up. So I start low dose. Let's say I'm giving 20 milligrams. I start with 1 milligram, and I slowly raise it up to reach 20 milligrams. So I don't start with 20 because the patient might feel the hypotension. I also plan to give it at bedtime, so I give it at night. Okay, so I give it usually at night when someone is already sleeping, because they don't have to get up so much like the person masalan is functional, having to go to work. They get up and sit. So there's a higher chance of them having hypotension. Okay, so two solutions. Start with a low dose and give it at bedtime. All right, and I also avoid adding any other drugs that might cause vasodilation. Okay, then another problem that might happen with those patients is something that we call retrograde ejaculation. So the semen might travel backwards to the inside rather than outside when ejaculation needs to happen. And this is a temporary problem that can happen with certain patients. Okay, alpha-1 selective antagonists, what are those? So the first or the prototype, let's say, is prazosin. Prazosin has a short half-life, has a first-pass metabolism, it's bound to plasma proteins, and also, of course, as any drug, we start with 1 milligram at bedtime, and I increase the dose upward. Okay? You're not responsible to know how much is the dose exactly. Doxazocine and tazocine have one additional advantage, or actually two additional advantages. Number one, they're longer acting. So 1 time a day dosing. Okay? Number two, they can cause apoptosis. Do you know what's the meaning of apoptosis?
Is the cell dying?
Yes, exactly, cell death. But this is a kind of a good cell death. So remember, guys, the prostate is enlarged. So it's good to have something يعني lower its size. Okay, so this is one advantage. It can induce apoptosis, a kind of good death, programmed cell death in certain types of, or in the prostate smooth muscle cells. Alfuzosin, silodosin, and tamsulosin. Those guys are selective to the urinary bladder. They will not cause hypotension or dizziness or sedation like the other drugs we talked about. Okay, so these drugs, they will block alpha-1, okay, but they will block that subtype that is present in the bladder mainly, okay? And which one is most selective? Silodosin. Okay? Which one is least selective? Alfuzosin. All right, so alfuzosin is least selective to the urinary bladder. Silodosin is the most selective with the highest number. All right? Side effects. When I say alfuzosin causes prolonged QT syndrome, this is a problem, guys, in the heart. Prolonged QT syndrome. Okay, so this is a type of irregular heartbeat or arrhythmia. Okay, and tamsulosin and silodosin might cause retrograde ejaculation. Is it clear, you guys? Do you have any questions about alpha-1 antagonists? Okay, now guys, alpha-2 antagonists, there's one drug, Euambin, and that drug is not used. You can find it as a dietary supplement because it might enhance male sexual function. I don't want you to know anything more about this. Okay? Yeah, guys, we're just going to talk about like a small introduction because again, we're so beyond the other section. Let me see how we can manage this. Okay, so now we're going to talk about beta blockers. And beta blockers, you guys, are divided into many types. Okay, so beta blockers are competitive, so they're reversible, okay? And they're beta receptor antagonists. They block, usually, when I say, guys, beta blocker, what's the first organ that usually comes into your mind? When I say beta blockers, any beta 1?
Heart.
Exactly, the heart. So those are the drugs that are best for the heart, although we have other reasons why we can give a beta blocker. Okay, so the intended action is for beta 1. This is why we have two types. The non-selective, which can act on all betas, and the beta 1 selective. So the non-selective, the prototype is propranolol. So guys, those are all drugs that can end with LOL. Okay, so we have propranolol. Propranolol is a competitive, non-selective beta adrenergic receptor antagonist or a beta blocker. So this is non-selective. It can bind to both beta 1 and beta 2. Whereas when I say beta 1 selective, this doesn't bind to beta 2. So this doesn't have certain side effects that we're going to talk about. And this is cardioselective. This is specific to the heart. Okay, it acts on the heart mainly. Okay. What about the generations? We're gonna see. We have a first generation, we have the second generation. The first generation are all non-selective. The second generation are beta 1 selective. And the third generation, guys, are both non-selective and beta 1 selective, but the third generation, guys, they have additional special properties that we're going to talk about because most of them can cause vasodilation. In general, guys, when I say a beta blocker, do you think there is an effect on the vessels?
On the vessels?
Yes. Do you think there's an effect?
No.
Of vaso in general?
No.
No. When I say beta 1, when I talk about beta 1 receptors, we're talking about the heart and the kidneys only. We're not talking about the vessels. The beta 2 receptors may cause vasodilation, but if we block them, what's going to happen? When I block a beta 2 receptor, no more norepinephrine coming. So in the vessels that undergo vasodilation, no more vasodilation is going to happen. Okay? Anyways, so usually the effect on the vessels is minimal. Usually, unless there is a third generation, and which is a special property and the vasodilation can happen. What are the special properties? There are many, okay? And the ones that are special only to the third generation, there you go. These are. But the first two are not special to the third generation. They can exist in any of them. So guys, the first one is called intrinsic sympathomimetic activity, which is a long name, but the meaning is that, so guys, these are blockers, right? But they have been found that some blockers are not, they can still activate the receptor. And this is a property of what type of activator? Agonist, antagonist, partial agonist, inverse agonist. If it can still...
Partial?
Exactly, partial agonist. Okay, so some drugs are partial agonists, you guys, are not complete antagonists. And for drugs that are membrane stabilizing activity, so those drugs can stabilize the membrane. So they have a local anesthetic property, okay? And they have this they have this property that we should be aware of. Some drugs can block alpha-1. What's the result of blocking alpha-1, you guys? What do we do to vessels?
Vasodilation.
Vasodilation, exactly. And we have other vasodilating properties we're going to talk about here in this slide. Okay, so there are some special properties, you guys, some drugs do have that we need to be aware of, just to know that these properties might exist in certain drugs. Okay, so guys, we have now a list of beta blockers. Nadolol, Pindolol, Propranolol, Timolol, Atenolol, Bisoprolol, Esmolol, Metoprolol. So we have a lot of lols that we have to be aware of, okay? So what are we going to know? So the first 5 drugs are first generation. These are the second generation. And we have the third generation. Third generation non-selective, third generation beta-1 selective, okay? We need to know these drugs, all of them, the drugs, not with the table, of course, just the names of the drugs and which class they belong to. How are we going to remember? I'm going to give you a trick. Okay, you listening?
Yes.
So, let's focus. No, guys, there's no running away from studying these 1, 2, 3, 1, 2, 3. Okay, so we have to know them. But telling the difference between those is the following. The drugs that start from the letter A all the way to M, so A, B, C, D, E, all the way to M, those are beta-1 selective. And starting the letter N onwards, those are non-selective. Okay? This is how we're going to memorize them. The letters from A to M, beta-1 selective. From N to the last letter of the alphabet, till the end of the alphabet, this is beta-1, this is non-selective, I mean. Okay? The trick does. Okay, so it makes you remember which one is selective, which one is non-selective. Is it clear?
Yes.
Like, let me do some tricks. Let me now try to, before I do that, let's just talk about those, okay? So, guys, we have a bunch of drugs that are extremely special. And the 2 most special ones are carvedilol and labetalol. Okay, so carvedilol and labetalol. Okay, we have also nebivolol that can be also special. So there are multiple properties that each one of those drugs might have. This is why we put them into a different generation, a third generation. Okay, now guys, I'm going to ask you, and you tell me what the effect is. Okay, if there's nitric oxide in the vessel, what's the result?
Vasodilation.
Vasodilation. Exactly, vasodilation. Type, if I activate beta-2 receptors on the vessels, what happens to the vessels?
Relaxation.
Yes, relaxation. So what happens to the vessels? Dilation or constriction?
Dilation.
Dilation. There you go. So also vasodilation. But when I block alpha-1 receptor, alpha-1 antagonism. So when I block alpha-1 receptors, what's the result?
Also
Dilation.
Also vasodilation. But guys, when I don't have any more positive calcium, so calcium entry blockade, so I don't have any more calcium ions going inside the muscles, the vessel. What happens to the muscle? It will relax, no more positive. So what if it was the vessel? What would happen to the vessel? Dilation. So guys, all of those cause vasodilation. Potassium channel opening. When I open potassium channels and positive charge leave the cell, making it less positive. This is also a blockade of the muscle, which is also vasodilation. So guys, so all of those are or will result in vasodilation. And notice that some drugs have more than one property. Okay, like carvedilol, for example. Okay. Now, the last one, which is antioxidant. Antioxidant, guys, oxidative stress, or what we call as reactive oxygen species, and all of these are bad for the cells. So when I give something that's an antioxidant, I'll be saving the cell. Makes sense? So vasodilation all the way with different mechanisms of vasodilation. Okay, makes sense? This is the same ideas, just repeated in a scheme. Okay? Do you have any questions? So, what we mentioned so far is that all of those drugs can either be non-selective, or selective, or third generation. Yalla, let's do the practice to see if you're going to be able to guess. Okay, so guys, try to try to open your mic so that we can easily communicate. And I'm going to tell you the name of the drug, and you, judging by the first letter, you tell me if it's second generation, third generation, or third. Try to remember third. Third, the two main drugs in third are carvedilol and labetalol. Labetalol is a very good drug in pregnancy, you guys. Okay? Yalla. Timolol.
Okay, doctor.
Yalla, timolol.
First generation.
First generation. It starts with a T. Thank you. Bisoprolol.
Second generation.
Starts with a B. So this is second generation. Yeah. Amazing. Guys, do you know the drug from the pharmacy? It's called Concor. Yes. Have you heard about it? This is Concor is bisoprolol. Bisoprolol.
Yes, for the hypertensive.
It's given, yes, it's given in some patients. But guys, by the way, these drugs are not the best drug for hypertension. We have other drugs we're gonna take next semester.
Yes.
Okay. All right. طيب carvedilol.
Second generation.
Third generation.
Third. All right. So this is third. The carvedilol has additional properties that we mentioned, causes vasodilation and has antioxidants. Okay, guys. So this is it. We're not going to continue with the practice. I think this is more than enough. Right. Therapeutic uses. Tell me, guys, which one of those you know? Do you know hypertension?
Yes, we know it's hypertension.
Okay.
And,
You know glaucoma?
Yes.
You
it's
know.
in the eye. It's the hypertension in the eyes.
Excellent.
And eye.
Excellent. We just explained heart failure. صح?
Yes.
Do you know what's the meaning of a myocardial infarction?
It
Yes,
is
the problem- problem-
membrane. There is enlargement in
Yeah,
it,
the
or I think
problem-
it's thinning.
No, it's easier
Heart
than
attack.
that. Heart attack.
The problem
Yes.
with the heart, yeah.
What happens in a heart attack, you guys? Why does a person suddenly هيك يعني they have chest pain and they have pain in their left hand and everything? Why? Do you know? Why is it an emergency? It's not like heart failure. It's different. Let me tell you what happens in a myocardial infarction. So guys, what happens here is that the vessels that feed the heart with blood and oxygen, they get blocked. Okay, so again, the vessels that feed the heart with oxygen and blood, they get blocked. And this is why no more oxygen reaches the heart and the heart tissues start dying. Okay, this is what we call as a myocardial infarction. It's an emergency. The person has to be in the hospital within minutes of this start of the myocardial infarction. Otherwise, the heart will die. Okay? Are you familiar with migraines?
Yes.
Yes.
A lot of people have
Yes.
migraines. Migraines, guys, are a type of headache where the person, this is a headache that's caused by vasodilation in the brain, okay? The reason why it happens, it might happen to any person randomly. And the person might want to live with the symptoms for the rest of their life. So it's something that the person can live with. Is it dangerous? It's not dangerous. But it's very painful for the patient to experience migraines. The patient has a headache that usually comes to half part of their heads, okay? So usually it's experienced in half of the brain. And usually it comes with symptoms like, for example, the person doesn't want to look at light. Any sort of noise might increase their headaches. They feel that their eye is gonna pop out. Yes, Mustafa?
It's called photophobia.
Photophobia, that's right. Guys, do you know anyone with migraines, or do you have migraines?
Yes, I have one.
Yes.
I do.
So yes, so many people have migraines. It's very, very common, and usually comes in degrees. So usually there are many drugs that the person can take to prevent migraines. So those are drugs the patient can take every day. Or there are drugs that can help the migraine attack after it happens. But usually we want to avoid or prevent migraines from happening in the first place. Okay, so beta blockers are good drugs to prevent migraines. This is also a problem that can happen in the heart, and that leads to the heart being weak. Okay, so this is also a type of heart failure, but it can happen in a different pathophysiology. I will not go in deep details into this. Angina pectoris. Guys, when I say the word angina, this means chest pain because of heart conditions. Okay, so angina pectoris also is related to the heart. Arrhythmias is irregular heartbeat, and beta blockers are a very good drug to treat arrhythmias. This is when the electricity of the heart is messed up. And finally, thyrotoxicosis. Guys, are you familiar with the thyroid gland and the problems with thyroid gland? You don't know about the thyroid gland?
We know the thyroid gland, but I'm not sure what it causes.
You don't know the diseases, you don't know hyperthyroidism, hypothyroidism. You haven't taken those? Interesting.
Like Dr. We take it, but we don't remember.
Alright. Thyroid gland, guys, is responsible for your metabolism. There are some cases where the thyroid gland can become very toxic when it starts secreting so much of its hormones. It becomes so toxic. So what's the result? One of the things that happens is that the person might start getting tremors, they might have so many symptoms, and this is what we call as thyrotoxicosis. Okay, and one of the things that might happen is heart conditions. So increase in the heart rate, tremors in the patient. And this is why, in this case, we have to give a beta blocker to prevent the heart damage in this case. Makes sense?
Yes, doctor.
All right. Okay. So let me see what I would start with now. How are you doing, guys? I think today there's a lot of information. How's it going? Can you bear a little bit more? Wallah, you're fed up.
Let's go.
Okay. Yeah. So I will explain a few things here, and those are the reason why beta blockers work in case of heart conditions. Okay, so when I block beta 1 receptors in the heart, what am I doing? I am decreasing heart rate and I am decreasing the force of contraction. So this is both a negative chronotropic and a negative inotropic effect. Okay, and this is good usually, guys. When does your heart increase in heart rate? This is when you're in a stress situation, we're doing exercise. This is the excessive activation of beta 1 that usually goes down. Okay, so beta blockers do not stop the heart rate. Okay, it only decreases what's extra. All right, and this is the importance of beta blockers in treating heart conditions. So number one, they affect the heart, they reduce heart rate, they reduce the force of contraction, and they usually prevent overstimulation of the heart because of stress, exercise, and because of certain diseases. And when we're decreasing those, we're decreasing the cardiac output. What is the meaning of cardiac output? Cardiac output, guys, is the following. You know, the heart rate, what is the heart rate?
It's the how many pumps the heart.
Yes, exactly. Number of beats per minute. So how much does the heart beat per minute? Okay. And what is the stroke volume? The stroke volume, guys, is related to the contractility of the heart. The stroke volume is usually how much volume in milliliters does the heart push out of its, does the heart push out or can pump per beat? All right. So again, doesn't work this way. So guys, the heart rate is how many beats per minute. The stroke volume is how much the heart is pushing blood volume, okay, out per every beat. So the cardiac output, guys, is usually how many or how much volume does the heart push out per minute. Does this equation make sense? All right, so this is the cardiac output. The cardiac output is how much volume does the heart push out per minute. And it's the heart rate times the stroke volume. Stroke volume is the same as the cardiac output, but stroke volume is per beat. Cardiac output is per minute. So in order to get the cardiac output, we multiply the stroke volume with the heart rate. So how many beats that exist in the whole minute. A second reason, you guys, why we might get benefit from blocking beta 1 receptors is its effect on the kidneys. Okay, so the effect on the kidneys can come from blocking renin release. And when I block renin release, I'm blocking the RAS system, which is bad for patients with cardiovascular disease, which is a very good benefit. And usually it stops the fluid from being trapped in the system. All right? Is it clear? Do you have any questions? Okay. For patients with hypertension, guys, beta blockers are good drugs, but not the best drugs for treatment of hypertension. Take a look. Hypertension, how does the blood pressure come? It comes from peripheral resistance and from the cardiac output. So what is a beta blocker, guys, doing to the cardiac output? Guys? Guys, are we all following, or did I lose you?
Yes, doctor.
Does it decrease it?
Yes, there you go. I told you, the beta blockers decrease heart rate and decrease the stroke volume, so they decrease the cardiac output. So cardiac output would be decreased. So what happens to the blood pressure?
Decrease?
Also decreases, of course. Okay, so those are the equations that tells us about the heart rate, about the blood pressure, I mean. Okay, so when we agreed here that the cardiac output decreases, we know that the blood pressure also decreases. All right? So this is why beta blockers might be good for hypertension, but we have so many better drugs. So this is not our favorite drug for hypertension. Okay? Number 2 is treatment of acute coronary syndrome. When I say the word acute coronary syndromes, this is another term for a myocardial infarction, which we talked about earlier. Okay? So, listen, guys. What's happening here in the patient is that the vessels that supply the heart, it will be blocked. Does any more oxygen reach the heart?
No.
No. Does any more blood reach the heart? No. So what's going to happen? The cardiac tissue might start dying. Okay? And this is a very, very big problem. So when you put the patient in the hospital, you have to reopen the vessels, and this can be done with a surgery. But until the person goes into surgery, you have to help the patient. Okay. Now, the first thing you want is that, or you want to keep in mind, is that in this condition, the problem is the heart needs oxygen, but it's not getting the oxygen that it needs because we have a blockade in the vessels. So what's the first approach? You want to decrease the oxygen demand or the need for oxygen. How do I decrease the need for oxygen? By making the heart pump slightly less. How do I make the heart pump slightly less? By giving a beta blocker. Make sense? Make sense, you guys? Again, guys, I want to know if you're understanding. All right, so the trick here is simple. The problem is we have no oxygen coming. So how do I meet the need of the oxygen? I try not to increase the demand for oxygen so that the problem doesn't escalate. So one of the things that I do, we have so many other things that we're going to do, but one of the things that we're going to do is that we're going to give a beta blocker. That beta blocker will decrease the action of the heart and the oxygen demand will be less in the heart so that the problem doesn't get worse. Make sense? Since we just mentioned heart failure, let's talk about heart failure as well. Okay, we just mentioned it. So when a person has chronic heart failure, he's been living with heart failure for a long time. We said that the best thing to do about a weak heart is not to make it work more. is to decrease the load on the heart. So I don't want, for example, stress to, if someone is stressed, to make the heart work more. I don't want any overactivation of the heart. So this is why it would be smart to use a beta blocker. The beta blocker, guys, will decrease everything. It will decrease the heart rate, it will decrease the oxygen demand, it will usually decrease so many factors that make the heart work more, so that the heart can work at ease without having to rush, because the heart, even if there's a lot of stress on it, it cannot work more because it's weak already. So let's not stress the heart more. So this is why it's important to get or to use a beta blocker, because we will be lowering the sympathetic firing, norepinephrine firing to the heart. And usually if this happens, the heart will be too exhausted. Okay, also, this part of the kidneys, the RAS system, plays a big role in congestive heart failure. So we'll be blocking this overactivation and fluid retention. You're gonna see, guys, patients with heart failure, they have swollen legs. Their legs are going to be swollen. Okay, so this is something that's very important to stop. And we stop it with the help of beta blockers when they act on the kidneys. All right. Do you have any questions?